Hey everybody, Ryan here, and you are listening to The Poison Lab. Today, we have another episode of Toxicologists vs. the Internet. I couldn't be more excited to bring you this episode with our special guest, Dr. Howard Greller. If you've spent any time listening to medical podcasts, you probably already know that name. Or maybe you know him as And Howard, the nickname he garnished from his podcast, the Dantastic Mr Tox Howard. Or you might know him as Ho G, the nickname he has on the Sirius XM Doctor Radio Emergency Medicine Show. I really couldn't imagine a better guest for our show. Dr. Greller is a practicing emergency physician, medical toxicologist, and addiction medicine specialist in New York City. He completed his emergency medicine residency training in Philadelphia and completed a medical toxicology fellowship with the New York City Poison Control Center. He's made numerous significant contributions to the field of toxicology. He has over 24 peer-reviewed publications, ranging from cognitive outcomes after lead exposure to managing opioid use disorder or the effects of inhaling coral vapor. Did I mention that he's also the author of the lithium chapter in Goldfranks? He is an inexhaustible medical educator. He writes educational articles for the Tox Hound, and he was the longtime showrunner of the Journal of Medical Toxicology podcast, as well as his own podcast, the Dantastic Mr Tox Howard, which is one of my favorite podcasts. So you might hear me nerd out a little bit on this episode while I grill him on his early career in medical media. If all that weren't enough, he also does an excellent job of sharing our medical stories with the community. He's a contributor to the Washington Post and is the co-host of a weekly emergency medicine show on Sirius XM Doctor Radio. I'm just so excited to bring you this guest. Now, as per usual, if you're just here for the cases, go ahead and skip to minute 22. Otherwise, just keep listening. We have a great time talking about his early career. Then we'll dive into cases, and finally, questions about drugs. We cover some great topics, like why the respiratory rate in the chart is always wrong, just exactly who is making poppers, and we even cover some interesting COVID testing techniques. Okay, and before we jump into our disclaimers, I do want to apologize to the audiophiles. We had a bit of a technical error before the show and weren't able to record our voices separately, so we had to use a few different audio files to piece everything together. There may be a few spots where everything sounds crystal clear, as if we were in your very own living room while you were listening, followed by a few spots where it sounds like we're on Mars. I'm sorry in advance, but this show's about the content and not the clarity of our sultry podcasting voices, so I hope you will forgive us. It's one of just a few errors that happened during this show. In fact, if you listen really closely, you might hear me refer to an emergency department as an emergency apartment. I think I'll take whatever we have here as a win. Okay, I don't want to keep you waiting any further, but here are our standard disclaimers. We're going to be answering questions on the internet from people who may be trying to use drugs for the wrong reasons. Anyone using illicit drugs is exposing themselves to risks of potential contaminants, wide dose fluctuations, and toxicities of the drug itself. While this gives us a medium to explore toxicologic concepts, we are not advocating for anyone to use illicit drugs. If you are struggling with substance use, call 1-800-662-4357 to access the SAMHSA free helpline and get the care you deserve. Second, we're going to be talking about real fatalities, and while this allows us to discuss a lot of great learning points, some of these substances were ingested intentionally. If you or a loved one are struggling with thoughts of suicide, someone's there to listen. 1-800-273-8255 is the National Suicide Prevention Lifeline. Please call. Finally, even though we're going to be discussing medical management, treatment, and diagnosis, we are not providing medical advice. If you think you're being poisoned or you have a general healthcare question, call your primary care provider or reach out to your local poison center at 1-800-222-1222. Now, let's get on with the show. Hey everybody, you are listening to The Poison Lab, a show about poisoning from people who manage poisoning. I'm your host, clinical toxicologist and emergency medicine pharmacist, Ryan. And we are so honored today to have a very special guest in-house with us, well, over Zoom. An inspirational physician and educator and someone whose work in the field of education and podcasting has really left a space for this podcast to grow. So I couldn't be more excited to welcome on Dr. Howard Greller.
Thank you. I'm a simple toxicologist, not the Dalai Lama.
Well, you know what? I'm going to let the listeners be the judge of that. Thank you for joining us. And for the listeners, we had a technological meltdown before the show. I wasn't sure if it was going to happen. So thank you for jumping through these hoops to ensure we could actually record the show today.
Of course. It wouldn't be a podcast unless there was a technical error.
I think there was a solar flare. I think that's a little background on Dr. Greller. This is the part where I'll probably embarrass him. But I'm just stunned at this mile-long resume of just impressive accomplishments in toxicology and education and medical media. You're a practicing emergency physician, medical toxicologist, addiction specialist, numerous important publications in the field of toxicology. You're a writer for the Tox Hound blog. I'm a big fan, by the way, of the urine drug screen post.
Thank you.
You have a very creative way with words and make everything very easy to understand. And this, of course, comes out in the podcast that you've been making. And then beyond just your work as a medical educator, which I don't understand where you fit more time in, you are the weekly co-host of the Sirius XM radio show, Emergency Medicine on Dr. Radio, which I believe you did today.
Just got back from.
Yeah. So I hope you were on voice rest yesterday so that, you wouldn't.
Yes.
You wouldn't.
A lot of whispering, hot tea, a muffler around my neck.
Well, the voice sounds great. And
thank you.
And on top of all of these things, you're also a parent during COVID in New York City.
That's definitely the most challenging of my jobs.
I imagine that does add a variety of challenges.
Yeah.
Well, thank you for joining us today. This show, listeners, as you know, we're going to do our standard discussions. We're going to talk about some questions about drugs from the internet, and we're going to go through some cases of fatal poisoning. But would love to really ask you a few questions about your fascinating career in medicine and toxicology. So,
sure.
If you don't mind, how did you become interested in toxicology in the first place?
It's a great, like I think many people that sort of go into emergency medicine, you're drawn to the variety. And one of the things that I found was that I kept on finding myself fascinated by not only people who had very clear overt toxicologic problems, so overdoses, substance use, things like that, but also really the biochemical mysteries of people that had, for lack of a better term, therapeutic misadventures. So like, grandma who's now on 17 medications and is now in the hospital and no one knows why. And that kind of, the mysteries and the problem solving, the detective work, that was the kind of stuff that got me going. And it was really exciting. And then I also had really influential mentors. So when I was in medical school, I went to medical school at NYU. And so I had interactions regularly with, Louis Goldfrank and Louis Nelson and Bob Hoffman. Wow. And then when I went to my residency program, I was, surrounded by Fred Henredig and Kevin Osterhout and Jean-Marie Perrone and Francis DeRusse. And so all of the people that had the biggest impact on my education and my, decision to become an emergency physician were emergency physician toxicologists. And so I kind of look back on it now like I was fated to do this because I was just surrounded by people like that. But it was just something that also just the subject matter really, really just excited me. And I was really, really excited to pursue that.
For the listeners, some of those names, Goldfrank, Nelson, Hoffman. I currently have a book propping up my laptop. It's called Goldfrank's Toxicologic Emergencies, and many of those names are plastered on the back of the book. So truly people who have done a great job of influencing toxicologic practice and clearly creating brilliant toxicologists. And that's something I hear over and over when I ask this question, is the mystery, where are these symptoms coming from, and being able to peel back the layers.
Yeah. I mean, and the other aspect of it that I think, and when I speak to different learners, is when we talk about medicine, capital M, right? The tool that everyone uses is in the name. We use medicine, right? And understanding that how you use the tool, why you use the tool, and understanding the tool better, I think is so important in terms of not only getting the outcome that you want, but also protecting from the thing that you don't want. And so that's toxicology, right? So it's the interaction of something with the body and its normal physiology. And when that physiology goes bonkers, that's where we come in.
Yeah, you step outside of that therapeutic window.
Yep. Never step outside of windows. Defenestration is bad.
Yeah, not good. I mean, you've had really a fascinating history. I mean, great career in toxicology, but then also in broadcast and media, such as, I'm going to have a nerd moment here, but I think Dantastic Mr. Tox, or potentially the JMT podcast, which I believe you were involved in. It might have been like one of the first podcasts I ever listened to. I think it was like I remember being a resident. I was in my PGY2 and EM for pharmacy, and I was listening to all these talks things. And I think I was flipping back and forth between Serial and the JMT, the JMT toxic podcast. So would you mind talking a little bit about how you came into doing not Dantastic Mr. Tox, but also the JMT and kind of what your drive was for those?
Yeah, so the history of that's really interesting. Well, it's interesting to me, not to any of your listeners, I'm sure. But when I was, I don't remember how many years ago this was now, but I was on the editorial board of the Journal of Medical Toxicology. And one of the things, I'm kind of generationally, I'm spanning kind of, a generation that didn't have computers and technology and then kind of did. So I span a little bit of both. Right. And I've always been a little bit tech oriented because my dad was a computer programmer before there was, the internet and things like that. So I've always had a finger.
First camera. You helped bring everyone to the technology.
Yeah. I, definitely an early adopter in a lot of ways. And so as part of my role on the editorial board, we were trying to come up with ways of attracting readership and to getting people the information that we had in the journal and disseminating it appropriately. Going to pause for a second to allow the siren to go past.
Oh, no problem.
Part of podcasting in New York City.
Yes.
If you listen to any of the Dantastic Mr. Tox, there is one point at every episode where my dog barks. So it's just part and parcel of it. So we were trying to come up with ways of promoting the journal, promoting the information inside of it, and to just kind of find a different way of engaging the readership. And so Dan and I were on the board together and became friends. And we said, how about this thing called a podcast, which most of the people didn't understand or know what that was. And they said, okay, we'll put something together and we'll take a look and see. And so we wound up putting together this rambling 2.5 hour stream of consciousness recording, which was absolutely terrible, but they loved it. And so then we worked on it, and we basically put out an episode with every issue of the journal for, I would say, probably 6 years. And kind of went through and highlighted the things that were interesting. And through that, kind of developed our rapport. And once we got to a natural end after doing it for so long, we handed it over to a new group and then decided to do something on our own, which, to be completely honest, we went through, I think, 4 or 5 different concepts, ideas, podcasts where I have hours and hours and hours of outtakes and other hosts and other things before we settled on Dantastic Tox.
There's an unreleased vault of outtakes.
Yes. I got to talk to Taylor Swift about, how to release that stuff.
Well, I mean, I've been a big fan of those shows for many years, and I really appreciate the content that you have put out. And also creating a space for toxicology, to talk about toxicology. I think there was clearly a need that you guys filled expertly.
Thank you.
Beyond the podcasting, which I love, and I can't wait for the 20-year anniversary release of all the secret tapes. Also moving into more medical broadcasting, like Sirius XM, Dr. Radio. I'll admit I tend to be more of a local radio person.
Sure.
Because I like to hear what's going on in my area. But then I was like, well, if I'm having Ann Howard on the show, I need to listen to this. And I listened to at least 3 episodes of Emergency Medicine, Dr. Radio beforehand. And I love it. It is so great the way that you guys, I mean, I love the questions you guys get and the ability to talk with the public as well as other, a lot of medical professionals are calling in. So how did you get involved in some of these other media outlets?
So, I mean, a lot of this is just sort of serendipity. The person that I do it with is Dr. Billy Goldberg, who, when I was a medical student and did my post-first year summer, internship between first and second year medical school, I volunteered in the ER for this research rotation, for lack of a better description. And he was a brand new attending in the emergency department, and we met and became friends and just sort of stayed in touch, throughout the years, throughout my fellowship. And when I came back to New York for fellowship, we reconnected. The origins of Sirius XM, I don't really know, or how Dr. Radio came about, but that show was the first show on the Dr. Radio channel, and Billy was the first host. In fact, coming up in 2 weeks is going to be the 14th anniversary.
Oh, I heard.
And so it's amazing. So he started doing the show, and about 6 months in, I saw him at a mutual friend's birthday party. He's like, why don't you come by, hang out, and we'll talk, like we normally do. And I did, and I never left.
Well, thankfully you didn't. It's such a fun show to listen to. The questions that come in, it's really fun. I had my first, I guess, more dedicated radio experience last week. Actually, they did an interview on our local Wisconsin public radio about the Poison Lab.
Awesome.
Which then kind of warped into talking about poison centers, and they accepted public callers. So that was my first time getting to jump into the realm of answering questions on the fly. So, people were asking about methanol and hypersensitivity reactions to chlorine gas and all these things. And it's like, I really had fun doing it.
It's so much fun talking. That's the best part about the show, is getting the talking to the public, because as opposed to sometimes the stuff that we do in the emergency department, you don't have that same freedom to have as casual discussion, because you're being pulled in a million different directions. And this is kind of a reflection of an old office where you can just sit and chat in a unpressured, except for the clock that segments the show, you can sit and have a conversation about people and really answer the questions that potentially they didn't get answered. So it's one of my favorite things I get to do. And I'm really, consider myself very lucky that I have the opportunity to do that.
Well, I think we're lucky that you're on that show, because listening and hearing you distill some of those complicated topics down to really understandable language for people who aren't really familiar with healthcare in general, or physiologic principles or medicine or the inefficiencies of our system. It's great to listen to. So,
that's a lot of practice. We step in it a lot.
Just in the few episodes I heard, I heard a lot about COVID therapeutics as well. So I commend you on your graceful.
Seem to talk about that a lot.
Yeah, well, in my state, we have this quarterback who he's got his own ideas about those as well. That was one of my first news things that I ever had to do, was a 30-second segment about ivermectin and how, in science, effects need to be reproducible under multiple observations and shouldn't have all of the data redacted later.
Yeah.
But, so I've spent a lot of time learning how to engage with people who are hesitant towards the medical system and believe in other therapies that some people are very good at convincing them are effective. So I give you a lot of credit. Listeners, thank you for letting me spend some time asking some questions I'm interested in. And I think everyone else would be interested in your history as well. But perhaps, can I ask one more question?
Yeah, of course.
Were you a comic in Los Angeles?
Yeah, so I did a lot of comedy during college, and then after college, I took some time off and I moved to LA, and I did improv and stand up for a little over a year before I went back to go to med school. Yeah, it was fun.
For you, I suppose instead of yes and, it's yes and Howard, right?
Yes and Howard, exactly.
That's perfect.
Exactly.
Wow.
Gotta get a tattoo now.
Yeah. Well, I think those skills have certainly served you well. And thank you again for coming on and lending your expertise to the show today. For our listeners, I think we're finally going to jump into our normal programming. So, listeners, as you know, on the show, we split it up generally into about two segments. The first one is Toxicologists versus the Internet. I'm sorry, we flipped the script. We actually do that one second now because we did a little poll and many listeners said they wanted to hear cases first. So,
okay.
I think we're going to jump right into some cases, and then we'll talk about the toxicologist versus the internet, which I think is a lot of fun. But the cases, so these are real cases sourced from usually the American Association of Poison Control Center fatality reports. The goal of this is for people to be able to hear someone's toxic differential as they are presented with a case of maybe an undifferentiated poisoning, and trying to figure out what that toxin is based off of their clinical presentation. And hopefully any medical listeners out there can be aware of how to identify this themselves if they're ever confronted with such a patient, or for the public to just be aware of the potential toxins that do exist out there. So the only rules are we can't give away any antidotes that would tell us exactly what the poison is. And that's essentially that, and we can't give out the poison. So, would you like to start? Do you want to read me a case, and I can show you how?
Yeah, sure.
Yeah, that's perfect.
All right, so let me see. I have a couple here.
I have to full disclosure. Dr.
Yes.
I did send the cases to me beforehand, and I realized it, and I deleted them all right away. So to the audience, Scout's honor, I have not read 99% of these cases. So.
Yeah, I also went back after I made that unforgivable mistake, and I pulled some more.
Oh, perfect! All right, good.
Just in case.
If I succeed, we will know it is all my own intuition, and if I fail, it is also all my own. So.
Yeah, exactly. All right, so this one, I think I won't give anything away. A 19-year-old who basically collapsed at home, was brought by EMS to the emergency department, was intubated, unresponsive when they arrived, GCS of 3, pupils fixed mid-range, was apparently re-intubated because I'm not really sure what happened with the airway.
Okay.
Vital signs, profoundly tachycardic in the 140s to 150s, hypotensive in the 70s over 30s or 40s. And remained that way after some initial pharmacologic interventions for that.
Okay. Maybe I could touch on just a little bit of what I'm initially thinking. Can I ask, when you said they collapsed at home, I know we don't have this information, but were they just standing at the kitchen and then collapsed, or are they found down, or we don't actually know?
Yeah, this was basically seen last normal by parent, probably within 20 minutes to a half hour.
Oh, okay.
And then, the other person in the house heard a, thump, and then they were found down.
Interesting. So somebody, I could just kind of walk through a little bit here, an immediate collapse followed by tachycardic and hypotensive.
Yes.
So when I think of that, I think of, well, in part, sometimes beta-2 agonism, or beta agonism, where we could see tachycardia is coupled with hypotension. Sympathetic toxidromes, usually we see tachycardia and hypertension. So this seems more like maybe something that caused a primary arrhythmia. Do we know what the QRS is on the EKG? Is this like a super wide QRS tachycardia?
Yeah, so there was QRS of 120 milliseconds.
Okay, so we have a wide QRS, tachycardia. If that's monomorphic, or heart rate of 140 to 150, this could be like VTAC, and that could be causing the hypotension. I know I would probably, if there's a known ingestion, this guy's going to be getting some bicarb, well, actually some hypertonic sodium to try to fix that. Now I'm thinking of things that within 20 to 30 minutes are going to make you collapse. One thing that jumps to my mind is dust off. If you're huffing dust off, you can, these are halogenated hydrocarbons, usually with fluorinated. And these can cause acute dysrhythmias, which could be VTAC that would lead to hypotension. So I don't think I know enough right now. Fixed pupils, who knows what that is, but this is my first start.
All right. So the patient, they noted the widened QRS. They gave some boluses of sodium bicarbonate, which led to some narrowing of the QRS down to mid-90s. And then they started to get some laboratory data back, which
this is where
the money lies. Yeah. So the initial blood gas had a pH of 6.9 with a PCO2 of 38 and a PaO2 of 153. Bicarb was 37 with a base X of 26. And the lactate was 20.
He had a lactate of 20. His bicarb was 37 and his base excess was 26?
I'm sorry, 3.7. Did I say 2%?
Okay.
My apologies.
I was like, wait a minute, something doesn't match up here.
He's
profoundly
acidemic. Missing the decimal point.
Anti-metabolic acidosis. Okay. I assume. I mean, a lactate of 20, you must. Okay. Lactate of 20. Anytime I hear a lactate of 20, I think cyanide. I also think sometimes metformin-associated lactic acidosis, but that's not going to cause this. He's not somebody who takes metformin and then went into AKI, or somebody who intentionally ingested a large amount of metformin. Are there any other labs? Potassium?
It is not listed here.
Okay.
Yeah, not listed.
Well, I mean, obviously, he's got a severe lactic acidosis. If we're running down the potentials here, there's quite a few. And you can also get a severe lactic acidosis from being in severe shock, having a low blood pressure and this high heart rate. But up to 20 is pretty high. When we see it that high, I usually think dead gut or toxins. Right. And with this high, so now I'm thinking of things that can maybe prevent cellular utilization of oxygen, which is where we tend to see shunting of pyruvate into lactic acid instead of acetyl-CoA. So I'm thinking maybe sodium azide, cyanide itself, which I don't know who has cyanide at home. Did he grind up a bunch of apricot kernels?
Sure.
And ingest them? Because you can have amygdalin, which gets metabolized to cyanide in the body from apricot or certain pits of stone fruits. Or, phosphine, I think, actually uncouples. So he could have taken zinc phosphide. That uncouples oxidative phosphorylation too. So I guess, is this a suicidal intent?
It is a suicide attempt, yeah. And you nailed it. I mean, it is cyanide that was purchased on the internet. But the other sources of cyanide, like you said, they have to always, one of the things I think we always have to think about is people's occupations or the occupations of people around them. So, jewelers and people that work in electroplating and things like that, electronics sometimes can have cyanide, depending on whether or not they're doing this at home. And then other sources, like you said, that, the prunus species that have pits that contain amygdalin, but there's also acetonitrile, which artificial nail remover has cyanide as well.
I believe that metabolizes into cyanide, acetonitrile?
Correct.
Okay.
Yep. This person had purchased cyanide salts online, and this was a suicide attempt. So
The amount of toxic things people can purchase on the internet is kind of befuddling. A little tragic.
It's amazing.
I remember a paper called Poisoned by Prime where they go through and categorize all the incredibly toxic substances that are available on Amazon. I hope somebody sees that in the Amazon headquarters, but who knows?
Jeff, if you're listening.
Yeah. Paging Bezos.
Yes, we're on a first name basis.
So did he get hydroxycobalamin?
Got multiple doses of hydroxycobalamin, so 3 doses with some improvement in vital signs, improvement in the blood gas, however, remained hypotensive even after 3 doses of hydroxycobalamin, and being on maximum doses of norepinephrine and dopamine. Sure. And then a head CT that was performed in a little bit of a delayed fashion showed diffuse subarachnoid hemorrhage and poorly differentiated gray-white matter. So they basically withdrew care and patient expired.
Any sodium thiosulfate?
It doesn't list that as a therapeutic that was given.
Ah, that makes sense. So for the listeners, cyanide, the most common reason we're treating cyanide is actually house fires. But it's a well-known toxin to be poisonous. So that causes some people to seek it out if they have, unfortunately, self-harm intent. Our treatments, we actually have a few, which is, that we don't actually have that many treatments for all that many poisons. But cyanide, we have hydroxycobalamin, which actually combines with cyanide in the body to make cyanocobalamin, non-enzymatically, which is really important. So it happens almost right away, and it's super helpful.
Which is cool. I think there's, this is an example of some of that elegance in biochemistry and toxicology that we see. So you take a poison, you add an antidote, and you make a vitamin. And I find that to be so, because you're making vitamin B12. So this is not the way that I recommend people getting supplemented with B12, but
it's maybe a
something.
Little, but absolutely. It's clinical biochemistry, and it's such a cool concept to think about. And the effects can be really profound on a patient. You can see a big increase in blood pressure after hydroxycobalamin. But then our other antidotes, we have sodium thiosulfate, which cyanide is metabolized in the body to thiocyanate, and it does that by combining with thiosulfate. It does this via an enzyme called rhodinase. So this is enzymatic. It takes time. You have to combine thiosulfate with cyanide with an enzyme, and it takes a while. So it's not necessarily the first thing that always gets reached for because it doesn't work immediately. But that's another thing we can use. And then the last antidote, which is a little, controversial, is inducing a methemoglobinemia.
Right.
Cyanide, negatively charged, loves positively charged things. It actually binds to positively charged iron in our mitochondrial oxidative phosphorylation system.
Cytochrome AA3.
So you can oxidize the iron in your blood, making it very positively charged, aka inducing a methemoglobinemia, and then ideally the cyanide attaches to that iron in your hemoglobin instead of the one on your electron transport chain.
Yeah, I think the controversy really comes from the fact that, again, as you said, most cyanide exposures that we see are from house fires. So house fires, you have this complicated mix of stuff that people can be exposed to in the smoke and gases that are produced. So a lot of times you already have someone who has thermal injury. You have someone who has smoke inhalation. So you already have one kind of hit to their getting oxygen. You probably already have some degree of methemoglobinemia induced from, inhaling multitude of different compounds.
Right.
And they're probably already sick and in extremis. So one of the things that the nitrates do by creating a methemoglobin, they also cause hypotension. So you're going to take a patient who's already in extremis, give them hypotension, and create further oxygen carrying deficit, maybe to offset a little bit of the cyanide. So, I think that in someone like this, who is also, who doesn't have that oxygen carrying problem, they have hypotension. So I don't think that giving them a nitrate is really going to make that much of an impact on a cyanide. So
And
Um,
I guess they don't have other hemoglobinopathies already. There's no CO bound on there. So yeah, you could.
right,
It certainly seems to.
right. CO is another.
I think that when you look at the animal studies, you really have to. It's been a while since I looked, but I felt like you had to push the med hemoglobin to like 30 or 40% sometimes to really get good binding too. So there's a question of efficacy too.
How
But
really
yeah,
effective it is. Yeah. I mean, I think a lot of the antidote kit stuff came from a study, I think it was in the late 60s by Way, where they took mice and they poisoned them with cyanide, and then they gave them combinations of antidotes. It's sort of like the combination that prolonged the survival of the mice the longest was oxygen, bicarb, thiosulfate. I think that was it, and probably something that induced the methemoglobinemia, so the nitrates.
yeah,
So, and that's where that Lilly kit, the original cyanide antidote kit, I think got its start.
yeah. And then they had the amyl nitrite. They used to keep amyl nitrite in the
Yep.
fire chief cars, so that they, if it showed up to a fire scene, they would wave amyl nitrite under the nose of a victim to induce the methemoglobinemia. But those amyl nitrites kept disappearing for some reason. Also,
Poppers, yeah.
Toxo here to keep you nerds up to date on the terms kids use these days. For any listeners not aware, popper is a slang term for inhaling or huffing alkyl nitrites for euphoric effects. Now back to your proper popper podcast.
There's a great article that was in, I think it was BuzzFeed, probably in the last year, about the person who makes poppers. The title, hold on, I'm going to find it 1 second. Okay, I'm going to send you the link so you can put it in the show notes. But the title of the article is "This Man Does Not Make Poppers," and he basically that's what he makes. It's actually a fascinating little history of sort of this industry, because it's used as a sexual enhancer.
Yep.
And that's why it often disappeared. For an antidote, it does make a little methemoglobinemia, but the one problem in a lot of these cases is that in order to use a popper, you got to be breathing.
Right.
If you're not breathing, you're not gonna work. So
yeah, I actually got a sample of poppers that we got tested. We had somebody go into a cardiac arrest from using poppers.
Oh wow!
So we like went on a goose chase trying to find what was in this nail polish remover, which is they call it acetone-free nail polish remover, and it says contains amyl nitrate. And I found that a lot of the over-the-counter poppers that people buy, they come from like one manufacturer in Turkey. So maybe that person's not making poppers, but somebody else seems to be. Anyways, well, great case. I think a lot of good points to talk about there. And I'm gonna give a ding. I think my overall guess would have been cyanide, so I'll give myself a half point. All right. In the interest of time, I don't want to keep you too long. Are you ready for a case?
Sure. Yeah.
Okay. Oh, so we have a 16-year-old female who presents to the emergency apartment 9 hours after taking 100 tablets of a medicine that she found at home in a self-harm attempt. She presents to the emergency department due to the development of vomiting that occurred about 2 to 3 hours after taking the medicine. On arrival, physical exam, relatively normal actually, or they don't document much. Blood pressure, 125 over 102, heart rate 64, respiratory rate 26, and oxygen saturation is 96%, afebrile, so pretty much stone cold vitals. In the ED, she was pale and lethargic and endorsed bloody diarrhea. An abdominal x-ray showed numerous radio-opaque discoid shapes, which we will assume to be tablets, in the gastrointestinal tract. Do you want labs, or do you want to take a quick... Is anything?
I'm gonna start a little bit with this before the labs, because there are a couple things that stand out right away besides the dramatic clinical presentation. So the delay is, I think, important between the ingestion and the onset. So I think 9 hours is enough time for absorption, and even if there's something that needs to be metabolized to the active component, that's something. In terms of the vital signs, there's one thing I want to, it's become a pet peeve of mine over the years, is that a respiratory rate of 26 is not normal.
That's a very good point.
And it's not picking on you. It's picking on all of us in medicine. Is that respiratory rate has become sort of the forgotten child of the vital signs, and a respiratory rate of 26 is not something that physiologically you can maintain with comfort. So most hospitals have a particular, I call it the respiratory multiplier, right? So you're an 18 hospital or you're a 20 hospital. And what you do is you measure one breath and then you multiply it by the multiplier.
Yeah, that's pretty consistent with what I see.
I got that from Richard Wolff, so I can't take credit for that.
I don't pay attention to it because it just never is correct. That's because I just assume it's the multiplier.
And that's exactly the thing. Is any toxicology patient, I mean, any patient in general, you should actually look at the patient. We're not all built of ultrasounds yet, but you should actually go to the bedside and look at the patient. And one of the things that you can do very, very easily is visualize their respiratory effort, which is not only the rate, but it's also the depth. And I think that gives so much information, because a lot of the things that we deal with either modify your respiratory effort or create conditions such as a metabolic acidosis that then modify your respiratory effort as a compensatory mechanism. So in this situation, a young person with a large ingestion who's now tachypnic, at least, and now is having bloody diarrhea, one of the things, and then something that you can see on x-ray, one of the things I'm going to think about initially is iron. That's going to be a big one that I'm going to be worried about, and that the respiratory rate is going to be a reflection of an underlying metabolic acidosis. That's where I'm going to start.
Would you like the labs?
Yeah.
They have an underlying metabolic acidosis causing a respiratory alkalosis. So we have a pH 7.3, PCO2 of 19. So absolutely. And they did check a lactic, which was elevated to 6.
Okay.
And I can give you a little bit more here. So she was started on a redacted antidote. Whole bowel irrigation was initiated due to ingestion history and the radiopaque foreign bodies.
Okay.
Within hours, she became more lethargic. Repeat ABG showed worsening acidemia. She was intubated, flighted to a tertiary care center. And actually, on arrival, they repeated an x-ray. She had cleared all the tablets, but she progressed to life-threatening liver failure, AST, ALT in the thousands, ammonia of 700, INR of 8. That's a high ammonia. She had hypotension requiring vasopressors. She developed hypoglycemia and remained intubated and unresponsive, getting some therapies for coagulopathy. But she was actually eventually listed for transplant, and then, but then actually recovered. But unfortunately, and on day 12, she developed a lower GI bleed and a bowel perforation, and unfortunately died due to complications of trying to fix that. But so, any further thoughts, I guess, on what our toxin could be?
Yeah, I mean, there are a number of different things. Again, the timing of it is interesting. I think that from the perspective of developing this rapid metabolic complication, the diarrheal illness, and then hepatic hit, you can think of some of the antimitotic agents as well. So, methotrexate, colchicine, diarrhea, metabolic acidosis, especially bloody diarrhea with radiopaque things. I mean, metals of other ilk. I think you said pharmaceutical tablets, so that's why the first place I go is iron.
Yeah.
But there are also metal salts that could be readily available in a medicine cabinet. So, lithium is something, shouldn't give you necessarily bloody diarrhea. What other therapeutic metals? Certainly some supplements, potassium could be something that could give similar, although you would expect to know about the potassium as well. Yeah.
Is there any one of these you'd like to?
I'm going to put my nickel on the iron.
And Howard wins a nickel today, everyone. The initial GI, diarrhea, vomiting right away. There are some texts, if you read, they, basically, if you don't vomit within 6 hours, you won't become iron toxic. So she had initial GI symptoms. And then, so iron is a caustic to the gut. And really, we see a lot of problems with that. And then when it gets absorbed, it just oxidatively destroys the liver. So we see liver damage, and then you see all sorts of progressive shock and hypotension from either directly from the iron and also from liver failure.
Yeah,
really unfortunate.
Yeah, iron's an interesting one also because there's a long history of exposure, and people talk about, toxicology. We often try and put together descriptions. Toxidromes are one example of this, but we used to talk about phases of toxicity. And there was always this discussion of the, quote, quiescent phase, right? So we're quiet, where the quiet referred to they're no longer having vomiting or diarrhea, but they're metabolically falling apart. And so it's not really, it's clinically maybe a little bit quieter, but from the perspective of the patient, they're really in bad shape. So I think that's why those kind of classic descriptions have gone by the wayside.
Yeah. All of those are always just anything that's a liver toxin. Tylenol, Amanita,
Tylenol, yeah.
Or death caps. Yeah, I mean, they're just quietly sitting there while the liver fails. Yeah. So for her, this case,
awesome.
Really tragic. Also, another example that some of the most dangerous substances are just over-the-counter ones. It blows my mind.
Yeah.
Tylenol, salicylate, iron, all things that can really wreak some havoc. And her initial iron level was in the 4,000s. When she presented, she was started on deferoxamine, which is iron chelator, and then within 12 hours, they actually had her iron level down to the hundreds, which I found mind-blowing. Or it might have been 24. I don't know if I buy that timeline. It seems pretty aggressive.
Yeah, that's really fast.
And deferoxamine, an iron chelator, causes the urine to turn Vinrose, as they call it, as iron. So my understanding is that they used to give you deferoxamine when they couldn't measure levels very well until your urine was no longer Vinrose. That was the...
Although it's not something that is always as clear as looking like a Bordeaux kind of thing. But yeah, I mean, and deferoxamine is also a therapy that has some natural limits to it, because the higher you go on the rate, the more likely you are to induce hypotension. And so you have a patient who, again, like we were just talking about with cyanide, someone who's already having consequences to their hemodynamics from their ingestion, and now you're adding a therapy trying to fix that, but you're also potentially inducing hypotension. And so that's, it's like dialing in the radio to get the right spot.
Yeah. And that's why a lot of times we'll start at a lower dose, and you kind of, crank it up slowly.
Yeah.
The other thing, this one is, I think this is probably a board question somewhere in the world.
Definitely on an in-service.
There is an infection you can get with deferoxamine. I don't think it developed in this patient, but Yersinia enterocolitica is an infection. It's a bacteria that actually thrives on iron, and basically the deferoxamine just serves it up to them. Chelates it away so that they can eat it, and you can get Yersinia sepsis. So if they spike fevers, you maybe get ID involved when that's happened.
Definitely.
Fascinating.
Yeah,
okay.
It's not a Z-Pack.
It's not a Z-Pack. I guess, do we even have time? I think we could try to squeeze. Did you want to try another case? Okay.
I mean, you can edit out enough of my nonsense that can fit in.
This is There's no unreleased vault for the Poison Lab. But maybe we'll do two quick cases. We can just we'll keep it more concise.
Okay. Lightning round. Okay. I'll make
Do you
this
have one
one.
more?
I'll make this one really quick for you.
Okay.
Okay. So a 7-month-old presented to the emergency department crying with a little bit of cough and vomiting, and developed somnolence and some upper airway findings, some wheezing, some retractions, a little bit of respiratory distress.
Oh no. Hydrocarbon or Tide Pod?
Perfect. Yeah. So this is a laundry pod.
Ugh.
Yeah. Yeah. I hate these.
And this is a fatality. Oh no. The 7th.
Yeah. Yeah.
Awful.
So
All the this must have been I wonder, did you source this from pre-2015?
yes.
Okay, so one of the great movements in tox is that one of the North American Congress of Clinical Toxicology conferences, we were presenting all these cases of Tide Pod, basically deaths or horrible outcomes, and every toxicologist with a Twitter took to the internet and started tweeting at Tide to maybe put in some child safety proof locks for these candy-colored hydrocarbon bombs. And I think they have done that, but I don't know if it's really have changed. And I do think we see maybe less of them now, but I don't have the actual data. But yes.
Yeah, there's a lot of trying to figure out exactly. So there are two problems with these. Number one, like you said, there's a little bit of caustic nature to them. But the other thing is that the membrane that contains the detergent has some kind of content that leads to profound and rapid sedation that no one has ever been able to elucidate because the companies won't release their proprietary information.
Ethoxylated alcohols, I think.
Something.
Yeah, just weird stuff that we don't know. Anyway, but yeah, so then these children would aspirate. They get a horrible pneumonitis. They need, airway support, and they can develop ARDS and some. Yeah, it can be bad. Good. Yeah. Good case. All right. Well, I think I earned a nickel.
Perfect.
This one I think is at least worth talking about. So, which one? No, we're going to do this one. Okay. A 32-year-old male presented 7 hours after taking 2 handfuls of a medicine and drinking alcohol. So he presented to the emergency department 7 hours after taking 2 handfuls. He'd been drinking and took some medicines in a self-harm attempt. Past medical history, alcohol use, and depression.
Okay.
In the ED, anxious and tremulous, although no clonus or hyperreflexia. His vitals were notable for tachycardia and hypertension, and he was given a benzodiazepine to kind of chill that out a little bit, and he received some fluids. Laboratory findings. ABG was actually normal, everything normal. Tylenol salicylate negative. He did have an ethanol concentration of 53, or whatever, 0.05, whatever. And then a urine drug screen was positive for benzos, THCs, and amphetamines.
Okay.
His anion gap was normal. Chest x-ray negative, EKG, heart rate 87, QRS 84, QTC 425. So nothing abnormal there. And
his presenting complaint was what?
That he did something to harm himself.
Oh, okay.
Sorry. Yeah, that's why he should have. His mental status started to decline, and he quickly had a seizure. We're about 8 hours out now. He was intubated. His QRS increased to 186.
Ooh.
Sodium bicarb drip was started. He became hypotensive, requiring vasopressor support. He was on multiple vasopressors, had an LVAD placed, interestingly. Echo showed dilated cardiomyopathy.
Whoa.
DRT was initiated. He developed refractory shock. He was given intralipid emulsion, no improvement, and he actually died. On day 3, he rested on. So,
okay. Wow. All right. So, initial presentation shortly after the ingestion, normal, and then you said 9 hours afterwards he had a seizure.
Yeah.
That could be a lot of things. Certainly the thing that if I had to pick one toxin that would make me, clench and be worried about delayed presentation with seizures would be a sustained release bupropion.
So who's got a nickel?
I hate this drug. I really do.
I know.
And here's the thing. This is solely from my perspective as a toxicologist, because I know that there are probably thousands and thousands of people that are helped with multiple different issues with this agent.
Hey, it's Ryan. Sorry for interrupting the show, but Dr. Greller's making a fantastic point, and it's something I've been meaning to bring up. Toxicologists disproportionately see the risk side of the risk-benefit ratio of medicines due to the nature of their consults. And the show is about toxicology, so the focus is primarily on complications from medicines and not necessarily the benefit that some patients get. In past shows, we've talked about ADHD medications, certain stimulants that can occasionally cause increased arrhythmogenicity or sympathetic toxidromes. And we've gotten feedback from listeners saying that some ADHD medicines were instrumental in creating a flourishing life for them. There are absolutely people who gain enormous evidence-based benefit from being placed on some of these therapeutic medications. This show is not about creating stigma around using medicines for legitimate medical need. So I just wanted to clarify that. We are talking about the risk side of the therapeutic window, but there are benefits. So just keep our perspective in mind when you listen to our discussions. Okay, back to bupropion.
But as a toxicologist, this one is in my top 5 of things that I do not like to hear about intentional ingestions. Really,
Absolutely.
It's bad.
So hard to manage. And
yeah,
there's toxicity from, number one, it's almost exclusively delayed products now, or extended release products. So, people will show up looking okay. And then they progress to seizures and very difficult to treat cardiac effects. It is now the number one, I just checked the last annual report, it is the number one most fatal single antidepressant in the United States. So we get 3 times as many calls about them as TCAs. So it's really, it's prevalent now and it's very dangerous. So it manifests,
it's got a lot of indications. So,
and I feel like people aren't always aware. So it can be a tough thing to treat. It's a gap junction blocker that causes really difficult to treat arrhythmias. It's in the same chemical class as bath salts. It's a cathinone. So it's actually a pharmaceutical bath salt that people are taking and causing horrible arrhythmias and delayed seizures. So for any EM folks, just realize this one can be a toxic time bomb too. So even if they look okay, this one might need some delayed monitoring. But,
this is one that if in a reliable history, I would consider decontamination in someone who's completely normal.
Yep.
And it, I do not do that lightly, but this is something once they start to go down the tubes, they're really difficult to manage without heroic measures. And so it's potentially really, really, really bad. We don't really have therapeutics for it.
Yeah. We've had multiple of these on ECMO just in the last year, and it's still hard to do it. You can't enhance elimination well. It's too protein bound. So it's unless you got some miracle things hanging around. Oh, this patient was whole bowel irrigated, just like you mentioned. So be aware, everyone. Be aware. Thank you for running through these cases. I think we talked about really some interesting treatment aspects and some very classic toxidromes that might present. Okay. Are you ready to jump into the next section? We got enough time to do a couple questions. I think it'll be.
Yeah.
So the next part we're going to do is called Toxicologists versus the Internet, where we will be sourcing questions from reddit.com/r/askdrugs. As our guests describe this place, one of the darker corners of the internet, which he's quite correct. So here we are to shine a light on it and hopefully provide some good science, some interesting discussion in the context of toxicologic considerations around questions that people really have. Can I read you some of the questions that I'm not going to ask? I just thought they were...
Yes.
The very first question I picked, it's called Meth and Anxiety, question mark, 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 exclamation, exclamation. I don't know that that's really even a question. But then he's, or they say, I know this causes anxiety. Is there any way to help? And I chose this because the answer I thought was interesting. Somebody says, you're looking for a sugar-free bag of sugar, man. So
That's brilliant.
I think they were putting quite nicely that, there are no free lunches in biology. You're not going to get to use that substance without potential for provoking anxiety. But I thought that was interesting. I saw a lot of chatter on the boards about new cannabinoids, one called 10F-ABD, just to remind you that there's all sorts of synthetic cannabinoids.
Many.
Produced all the time. And my other question that I'm not going to read, I'm not going to pose because I don't want to know the answer, but it was, do pharmacists actually know anything? Question mark.
I saw that one.
I laugh. I read their story. They had a plight that they had been dealing with. I understand. And they're sometimes the healthcare system can fail us. I know, but I thought it was funny. I hope some do, Anyway, so those were the funny ones, but we're not going to talk about those. We're going to try to dive into some real questions. So I have one here that I'm going to pitch to you, and I thought this was a good one because it's pretty relevant. So one of the users on the board was asking, what are the most common substances used to cut drugs with? And, do they impact someone's, their high or their health effects that they can cause? So, Dr. Greller.
That's really fascinating. Yeah. So I'm trying to think of where to start with this.
Right.
The pharmaceutical industry cuts drugs as well, right? So that's, I think that's something that we should understand, in that when you take your pill of whatever you're taking, acetaminophen, salicylate, or whatever, the amount of drug that's in there is what the dose is, depending on its kinetics and its release formulation. But to make up the rest of the pill, there's stuff, right? Starches and colors and, parts of the release mechanism. And so the acetaminophen you're taking, depending on the form you're taking it in, is cut with other things. So it's not just illicit substances that are participating in this. When it comes to, illicits, there are multiple reasons why someone would cut their product, both from a standpoint of, avoiding detection, from trying to spread out or, make the supply last longer, enhance the impact of taking the drug, right? I think there are things that, you can sort of break it down into two different categories. There's something that would be more of an adulterant. So that's something that's active. And then something that would be more, I guess, better described as kind of a, I don't know, diluent always makes me think of liquid. So it's not really, but it's diluting out
a bulking
the thing, and it's not a bulking. Yeah, that's probably better. So, it's to spread out the supply, make it last longer, right? So if I have X amount of heroin and I can now make it 2X, then I can make double my profits. And there's so many different things that are used. Certainly there are things that we, encounter commonly, amphetamines and things like that. But then there are other things that have led to problems, as we've seen with a lot of our cocaine supply. And then there are things that are, I'm not quite sure what the rationale behind them are, but like fentanyl showing up in everything, right? Yeah. So it's showing up not only in other opioids, but it's showing up in cocaine. It's showing up in pills pressed to look like, benzodiazepines. Yeah. It's been looking or put in things like, there are even case reports of marijuana, which I don't understand the rationale behind it, but it's there and it's everywhere. And then we look at things like in cocaine, like levamisole, which is an antihelminthic, which there are lots of theories as to why it's there.
You got to cure the cocaine worms.
Exactly, right, for the formication. But Yeah, there's many different things and many different ways that things can be cut, and not all of them are beneficial to the user. So,
Right. Levamisole cellulitis, very
yeah,
vasculitis
vasculitis.
that occurs. Yeah, very, very nasty. I think levamisole has some psychoactive,
Yeah,
and a metabolite becomes like sympathetic, so maybe they're trying to enhance the effect. But where do they get this stuff? I don't understand.
yeah.
Yes,
Uh,
but absolutely
Amazon,
great review. Yeah, Amazon,
right?
Amazon. Yeah. So many agents, many things. They can be psychoactive or inert, but usually not good for you. That's for sure.
Yeah. All right,
Oh
I
yeah.
got one for you.
Okay.
I'm trying to decide which one to do first, but we'll do a real one first. Can I get high from nutmeg?
Oh, well, you can. I don't think you're gonna like it, but
Right.
uh, you're referring to myristicin. So
Yeah.
nutmeg contains in it a couple of psychoactive uh, substances. We don't fully understand the pharmacology of all of them, just like honestly many drugs. But myristicin is metabolized to an amphetamine-like compound in the body, and supposedly can cause a sympathetic, toxidrome. Although when you look at the literature, it's a little bit split. There's some actually anticholinergic stuff that also happens. So we don't know what exactly is the intoxicating substance, and like many plants, it's probably a lot of things. But people have taken larger quantities of nutmeg to induce these psychoactive effects, and generally not something that I think a lot of people repeat. But it certainly don't recommend doing it because they are, biologically active compounds. But people can do it. For the listeners, I think we actually talk about this in episode. There's one in the Mad Honey episode, which I think is episode
Ooh,
5 or 6. So
bryotoxin.
one of the readers, one of the listeners sent in a guess that it was nutmeg. When it happened to be Mad Honey, but we went into a little bit more in depth about that.
Toxo here with a factual correction for Ryan's flawed human memory. The episode where Mad Honey is discussed as episode 8. The episode where nutmeg toxicity is discussed as actually episode 6 where synchronism is covered. Now back to the show.
But yes, absolutely, it's
Nice.
possible. Don't recommend it.
I think that myristicin, like many compounds similar to it, has some weak MAO properties to it. And I think it's metabolized to MDA or NMDA.
Yeah, it's like a phenethylamine,
Yeah.
basically. And
Yeah, I'm sure Shulgin will let us know
yeah,
in the comments.
unfortunately, not anymore, but all right.
I know.
Yeah. Let's see. Yeah, MMDA.
NMDA, okay.
But good question. Love it. Interesting things you find in your pantry.
Yes.
I have another one for you if you've got the
All
time.
right.
Okay. So I'll read you the question, and I'm going to read you my favorite answer. This question was, are whippets detectable by any drug test? So for the listeners, whippets are nitrous oxide. And then the answer by this user says, only if you're still holding the whippet. I thought maybe we could talk a little bit more about what do you think? Are whippets detectable?
I don't think that we have any certain like therapeutic monitoring for it.
No test I can think of.
I mean, whippets are nitrous oxide, and nitrous oxide is, an inhalational agent that, depending on how you do it, there are a couple of different problems associated with it. So, number one, this is the occupational hazard for dentists, right? So they have the blue tank, and this is used recreationally to make you high. It's not really clear how it does it. It's thought to mediate many different neurotransmitter systems and receptors, but I'm not sure if there's any one that predominates. And it's used as sort of an anesthetic. And so if you put the mask on with the nitrous oxide and you become obtunded or insensate and you don't take it off, then you basically are breathing a non-oxygen environment, and then you become hypoxic, and that's one of the ways of fatality. And that's more of related to how you do it. From the whippet standpoint, I think it's an interesting thing. In England, use of this is called nanging, which is a kind of a nanging. Yeah, it's kind of a weird way of saying it. Your tongue pushing up against the roof of your mouth. Nanging. And you use this to whip cream, right? You don't use carbon dioxide to whip cream. You use that to make seltzer, because if you use carbon dioxide to whip cream, you'd spoil it because it's acidic. So this is neutral. And so this is why this is used. Yeah. It's a little detective work. It's a little fascinating history. But the other toxicity that happens with it is that it leads to essentially a functional B12 deficiency. So we're circling right back around to our hydroxycobalamin cyanide. It's all vitamins. It oxidizes the cobalt in vitamin B12, making it non-functional, and then you wind up with the problems of a vitamin B12 deficiency, even though you have normal stores and normal levels of B12. So you get anemia, you get a demyelinating disease, and this is typically in chronic heavy use. There have been a number of cases that we've seen over the years where, like, a roommate has found their roommate, they're unable to walk because they have this long tract demyelination, and they go into their room, and it's basically the entire floor is covered in these little silver bullets because they just go through boxes and boxes and boxes of them. One other toxicity of sort is that in order to get this is a compressed gas. And so they have to use a device called a cracker in order to get into the vial. If you do this directly into your body, into your mouth or your airway, compressed gas, number one, leads to, very cold, right? Mm-hmm. It's a endothermic, and then also under pressure. So there have been cases of people who have had cold thermal injury to their airway, as well as sort of like dissection along the soft tissue spaces, and those can be bad.
Yikes! Yeah, it's like a barotrauma. Yeah,
it's barotrauma. Yeah, but I don't think that you can detect it.
Yeah, I don't think there's a detection. I was thinking, just like you said, more you can maybe see the manifestations of disease from it, like a macrocytic anemia from your B12 deficiency, and neuropathies from its chronic use. Just like poppers, they both can cause these oxidating problems from cobalt oxidation. Right. But yeah, exactly. But I think because nitrous oxide is quickly metabolized, I don't think there's anything you can look for.
I'm not aware of it.
Yeah. Well, fantastic.
Cool. That's a cool one. All right. This is the one I think we both wanted to ask.
Oh yeah.
This
is a good one. Yeah. It's an easy answer, I think.
Yeah. Will my COVID PCR tests show cocaine?
So is he asking if cocaine is in the DNA of COVID? It's a good question. It really just highlights that all the different tests that are out there now are very confusing to a lot of people.
Yes,
I understand that. There's a lot of ways to test for COVID. You can do a PCR test, and by the way, none of them will show cocaine. Probably none of them. Maybe somebody came up with the combined cocaine COVID test.
That'd be amazing.
I haven't seen it.
15 minutes.
Yeah, exactly. The test itself, a PCR, basically is a polymerase chain reaction. That's what it stands for. And it uses an enzyme that looks for a little touch of DNA from COVID. And if it's there, it will replicate it over and over and over and over. So you actually need these base pairs, the DNA base pairs, in a specific sequence for the enzyme to match up with it. Cocaine has no base pairs. So it's not going to trigger on a PCR. If you have a large amount of cocaine residue, it might interfere with your specimen, but it's not going to read. Cocaine contaminant cannot read the PCR. But
right.
Good question.
And depending on your route of cocaine use, there have been. I had a patient where we did, COVID testing. They were there for COVID testing, and the swab went through the septal defect that they had in their nose because they had been a heavy cocaine user and they had basically had a septal perforation. So it was an interesting swab. But they didn't find the cocaine.
That is good. Well, I can think of no better question to end. Oh, you know what? I was really hoping we would get to the gabapentin serotonin syndrome question, but I think that'll have to be for another time. Only because I wanted to bring up how little we know about the mechanisms of some drugs, and it's so frustrating to me.
That's a good one.
We're just like, I don't know. This drug, like imagine if you had a really great, like this finely tuned engine in your car, and then sometimes you just add something to it and it, slows it down a lot. And you're like, I don't know why or how it does that, but it does, so we're going to keep using it. That's kind of like gabapentin.
Yeah.
It's pretty frustrating. And a lot of drugs that we just kind of assign mechanisms to that actually have a lot of different mechanisms, like Lasix. Lasix, everyone calls it a diuretic, but, also increases prostaglandin synthesis, all sorts of interesting. Anyways.
I mean, I don't think if there's any better example of that than lithium, right?
Oh.
We've been using it for 60 plus years, and we still don't know how it works.
Yeah.
And it's the simplest drug that exists.
But yeah, it's like one of the first elements that existed, I think.
Yeah. Amazing.
Well, okay, I'm going to stay off the soapbox. I want to leave enough time to thank you for coming on the show.
Thank you.
Providing your toxicological insight. I had a lot of fun. Are there any words of tox wisdom you want to leave with any incoming medical learners or people out there listening?
Yeah, I mean, just really the basic things is just, listen to your patients because they're going to tell you all the information you need to know, and examine them because that's going to fill in the gaps where they're not telling you. And I think that can get you really, really far in evaluating somebody.
Make sure you actually confirm the respiratory rate. That's it.
Yes. Respiratory rate 2022.
If it reads 2022, that's a problem.
Right.
It's been an absolute pleasure to have you on the show. I know you got to get going, so thank you
Thanks,
so
Ryan.
much for joining. I look forward to seeing you maybe in NACCT next year. No.
Yes, for sure.
Okay.
Awesome. Thanks again.
Wow, Ryan, what a top-notch guest.
I know, right? That was a great episode.
You might want to summarize some of the things you two talked about for the listeners, especially since you tended to ramble.
I suppose you're right. If an otherwise normal, healthy person collapses and has a lactate of 20, there's a few toxins that might jump to mind, like inhibitors of mitochondrial oxidative phosphorylation. Now, keep in mind, other things can cause a lactate of 20, including medical conditions like an ischemic gut or someone who just had a seizure moments before you drew the labs. There are even cases of alcoholic ketoacidosis with lactates over 20. And of course, other toxins. Ethylene glycol can get misread as lactic acid when it's metabolized to glycolic acid. Metformin can cause a metformin-associated lactic acidosis, but this is usually delayed. So the combination of sudden collapse coupled with extremely high lactic acid in someone who was previously asymptomatic should really make you think mitochondrial oxidative phosphorylation inhibitors like cyanide, sodium azide, zinc phosphide, or even acetonitrile, which does need to get metabolized into cyanide, so might be more delayed. Iron causes severe nausea and vomiting, followed by horrible GI toxicity and eventual liver failure, coagulopathy, and sometimes death. We treat it with deferoxamine in very severe cases, and complications of deferoxamine include hypotension and potential infections from Yersinia enterolytica. Bupropion is a very lethal and difficult to treat antidepressant. These days, we see more calls about bupropion than we do with tricyclic antidepressants, and it's the single most lethal antidepressant. It is a derivative of cathinones, like bath salts, and thus it has sympathomimetic toxicity as its toxidrome. We often see delayed seizures due to the delayed release formulations, followed by sympathetic toxidromes and very serious cardiac conduction abnormalities. Treatment is difficult. Sometimes we use lipid or ECMO, but there's no real definitive strategy. Laundry detergent pods can knock a kid out and cause a horrible aspiration pneumonitis. Many agents are used to cut illicit drugs, either as bulking agents to stretch the supply further, or as a psychoactive additive to try to increase its psychoactive effect. They usually can cause many complications. Some illicit cutting agents include fentanyl, levamisole, lactose, and, well, just about anything you can find. Whippets are called nanging in the UK, and you can really only test for it if you catch them with the bottle. You can, however, detect the effects of chronic use, such as macrocytic anemia from rendering your cobalt ineffective, as well as a demyelinating neuropathy. Finally, and most importantly, no COVID test to date. Tests for cocaine. Okay, I think that'll wrap it up for today. Thanks so much for joining us. We had a great time talking about these topics. If you like what you're listening to, go to wherever you're listening and leave us a 5-star review. Please put a comment about what you like most. This helps us share the show with other people who are interested in learning about these topics. Don't forget to follow the show on social media so you know when we release new episodes. You can follow us on Twitter at LabPoison, myself at EMPoisonPharmD. Our Instagram is Tox_Talk. We have a Facebook, The Poison Lab. And of course, all episodes, free games, lectures, and medical resources are available at www.thepoisonlab.com. We will be releasing the details for our next case. If you think you know what the cause of the toxicity is, I need you to write in to toxtalk1@gmail.com so you can take part in our next show. Your guesses make half of the learning. We get to hear your differential on what you think the cause of the toxicity could be. Okay, thanks so much for listening today. Hope you can tune in next time. Toxo, can you play us out?
The information on this show is for educational purposes only and should not be interpreted as medical advice or treatment recommendations. Contact your doctor for health questions or call your local poison center at 1-800-222-1222. The opinions expressed on this show do not represent those of our employers. This show is poorly written and shoddily produced by Ryan Feldman. Don't forget to give it a share with your nerdy friends. See you next time. Ta for now.